things. So I think there's a need to have ongoing focus in this area. Thank you.
Thank you, Dr. Idris. You have been very much supportive to us, and you have been helping our session as well. And actually, it is a mutual help to each other so that our remote and rural area healthcare, they can learn from each other. Thank you.
That's right. Yeah, thank you.
Yes.
Just to add, you know, we are in winter in Canberra, -4 in the morning. So I mean, it's a bit different to the settings. We are in the South Pole, near the South Pole.
So because we have many presentations, so I think we would like to start on time or a little bit ahead of time. So I would like to introduce Professor Dhananjay Sharma. Most of us, we know him. He is MBBS, MS, PhD, and also DSc, Doctor of Science, FRCS, FCLS, FRCST. He is honorary member of France Surgery, National Surgery, and he has Department of Surgery, NSCB Government Medical College, Jabalpur. He has many publications. He has very much interest in this academics, and he's very much interested to teach the students. Last time he had visited Nepal, Kathmandu, and he taught many of our students, residents, and he talks about life in a doctor, life in a surgeon, and apart from medicine, he also gives lecture on life issues as well. So we liked him very much, and I was grateful to him because I got the chance to be with him, connected. So thank you, Professor Dhananjay Sharma. Sir, would you like to start your presentation?
Yes. Can I share my screen? Thank you very much, Dr. Uday, for your kind introduction. It's always a pleasure to join hands with people who are interested in serving the people who have been disadvantaged. So today's topic, which has been allotted to me, is frugal ideas for operating rooms and teaching during the COVID-19 pandemic. This is where I come from, exactly the center of the country, central India, exactly the center. And I was quite pleasantly surprised by listening to a previous speaker, Suleiman Sir, that he is near North Pole and the temperature is -4. Sir, my part of the country, we have only 2 seasons, hot and very hot. So right now it is only hot. So good afternoon to sir, good afternoon to you. You can find all our publications on our webpage, everything, all the links are there. So let me start with what I'm going to speak on. What is this frugal innovation or frugal ideas? Frugal ideas mean doing more and better with less for more people. Very easy to remember. And what it signifies is affordability, adaptability, and accessibility, making it easier to people who deserve it. Now, it's a long journey with many milestones. The COVID for last 15, 16 months has actually changed the world. I don't have to tell you, nobody has been untouched by it. So let's start with frugal solutions for operating room. When the fear of virus was at its peak, everybody was speaking about filtration, ventilation, and negative pressure flow. So I kept on thinking how an ordinary surgeon working in a small hospital, a standalone hospital, is going to fit a filtration plant in his operation theater. It is beyond his financial scope. So what I decided was that we can use a big exhaust fan and that will take care of the circulation of the air. So that is what we have been using, and we published it long ago in British Journal of Surgery. Another thing which we thought was, what about the laparoscopic gas filtration? The machinery which they were suggesting was again very expensive, but very easily it can be done by HME filter, which is attached to the anesthesia machine. And the moment the companies realized, they came out with disposable models costing less than $1. So everything is now within our reach. Finally, what about the open surgery, the cautery smoke? People were afraid to operate. I thought, why not fix the suction cannula to the cautery tip? Keep the tip 1 centimeter proximal to the cautery tip, and you can take care of the smoke. Very easy. These things are already with you. All you need is a rubber band. That is all you need. Next, so many guidelines were coming, but these guidelines were all made mostly by Western countries' authors, and none of them were thinking about easy understanding, resource optimization, geographical inclusion, and economic implications. So we again wrote in British Journal of Surgery that these points have to be included in any guideline coming for COVID. And we called it emerge: evidence support, methodology, ease of understanding, source optimization, geographical inclusion, and economic implication. Emerge. I don't like it when somebody calls me coming from a third world country. I always try to correct them and request that please call us emerging economies. Don't label us at the global south or third world countries. It, somehow is not very courteous and respectful. We have large number of people who are working around the clock to do this, project our countries as a emerging technology or emerging economies. COVID also impacted surgical training. A lot of changes took place, and we could not encourage the students and the residents to come in close contact with the patients. So what we needed was, we conducted a boot camp, how to do things online. We shifted to online mode and conducted our first boot camp for this. And finally, we came out with a GRASP model of self-assessment. Finally, when the resident is working away from the teacher, who is not there physically present to guide him, to mentor him, to assess him, he has to have a module of self-assessment, and the mentoring has to shift to virtual mode. So this is what we did, and published it in Indian Journal of Surgery about the GRASP model: gain, recognize, analyze, simulate, perform. And at every step, the assessment is going on and virtual mentoring is taking place. So this has been a successful formula and module for us, and we have been practicing it. Now, finally, we have so many doctors, so many surgeons, so many teachers working with us in the developing countries. What about reverse education? Everybody talks about reverse innovation. We can offer the services of all these people if there is a shortage of virtual mentoring, virtual teaching in developed countries. We have the resources. So we wrote about it in BMJ Global Health long ago, reverse education. And I have been taking classes in various universities, including Vienna University, Oxford University, so many universities. And we have been able to help our colleagues there with education. So this was one of our landmark publications, Fast and Frugal Innovations in Response to COVID, and it was published in Nature Medicine. And we spoke about what are the innovations which work. So we made a big chart and started with which are the medicines which have been repurposed for COVID. So there is a big list, but we'll first start with repurposed ICUs. Operation theaters were converted into ICUs. We converted our wards because we installed oxygen pipelines. We installed ventilators in the ward, and we repurposed our wards and operation theaters into repurposed ICUs. So many success stories. Every country, every hospital has its own success story, how they utilized the beds and converted them into ICUs. The biggest success story was prone self-ventilation. The anesthetists used to talk about it, but we never heard it, and we never, struck us that how easy it is to improve ventilation. Prone self-ventilation.
Sorry, Dr. Sharma. I'm sorry to interrupt. Hello, Dr. Sharma.
Yes, sir.
The voice is, I'm sorry to.
Go on, sir. Tell me. Tell me, sir, can you hear me?
We have a double voice. We have a double voice of you.
Sir, must be something at your end because I don't know how to help. We can see
Okay.
technically. Dr. Uday, can you hear double voice as Suleiman sir
Okay.
is saying?
All right. I think it's my problem. I'm sorry. Thank you. I'm sorry. Thank you.
Okay, no problem, sir. So biggest success story was self-ventilation, and it was advised to even patients at their home. So self-ventilation, a success story. What about repurposed drugs? So many drugs were advised, but what was happening? They all came with a bang. But final results were not so satisfactory. Initial results were all, this is the abstract and this is the introduction of a paper, but final results were not so successful. So starting with drugs on the virus from remdesivir to doxycycline and drugs acting on the host from chloroquine to dexamethasone. Only dexamethasone showed good results. Hydroxychloroquine, everything fell aside. With the passage of time, when more scrutiny was done, only one thing worked, apart from oxygen, was dexamethasone. Lot of immune boosters, especially in India, zinc, magnesium, vitamin D. What worked for us was basil, Indian herbs and spices, which are known to have immune boosting properties, and the respiratory exercise by traditional yoga. So these things worked. We also got the benefit of ventilator multipliers. All you need is a Y-shaped connector, and one ventilator, you can ventilate 2 patients. Similarly, central oxygen multipliers, again a Y plug, something which fits in. You can see here the Y shape, and with this 1 point, you can give oxygen to 2 patients. What about this? This is the best example of frugal innovation. 1 oxygen cylinder, using the stethoscope to give oxygen to 2 patients. Very simple idea. You just have to make sure you use your most prized possession. Many low-cost ventilators were developed, including by several universities. DRDO is our defense organization, and they developed a very simple low-cost ventilator costing less than $700. Another success stories. What about protective aerosol box for intubation? Dr. Uday, this is from Nepal. Do you know this anesthetist? He avoided exposure to the patient. This publication was in New England Journal of Medicine from Nepal. If this box is not available, they also use transparent plastic sheets, cut just 2 holes in them and put the hand inside and intubate. And 2 assistants can hold the plastic sheet. What about do-it-yourself face mask? All types of face masks have been used. What about this one? This is a typical Indian modification. Typical Indian modification. Those who have seen Indian ladies wearing sari, they can enjoy the humor about it. Finally, we realized that face shields are very important. And face shields earlier were made for industrial purposes for safety, but then they started making it for healthcare workers. The simplest was a plastic cover, just a punch. You can fix it to your specs, or you can fix it to your mask, and you have a nice face shield costing practically nothing. Very simple do-it-yourself face shield. Initially, when there was shortage of PPE kits, this is one of our alumni surgeon taught by me, and he made it from a very low-cost raincoat. Same thing by the raincoat, and plastic wrapper. Same thing has been made. Head shield as well as, and you can see he's using ordinary plastic bags. Are you aware of this term jugaad? Jugaad is, very frugal innovation. So they came out with this. Lot of toothpicks are being kept in the lift, in the elevators. Don't touch anything. Just pick up a toothpick, use it to push the button, and then drop it in the trash bin. Similarly, distance, all types of social distancing. This is from Thailand, shared by one of my friends in Thailand. This is how they practice social distancing in the elevators, in the lifts. This is very common in the banks and offices, just tying a couple of ropes. So social distancing is there. Similarly, a transparent plastic apron, again, a very simple idea. Same transparent plastic apron in auto rickshaws or tuk-tuk as they are called in Southeast Asia, or plastic sheets in banks and offices. Very, very simple ideas. One of the success stories which was not utilized was Indian government requested the Indian Railways to convert various railway coaches for isolation. Sorry for the spelling defect. I didn't realize it should be isolation. So, but they were not utilized because many hospitals were able to cope, and sometimes they converted stadiums, marriage halls, and so many other things for isolation. But they could repurpose many coaches, and it was a success story. But as all of us know, the biggest success story for frugal innovation in the face of COVID pandemic is vaccine. Doesn't cost much and offers possibility of safety. So everybody talks about value for money. You buy a telephone, a mobile phone, you want to have this MP camera, that much memory. We have to remember value for many, because millions of people survive on less than $2 a day. We have to include them. And this is my request to all my colleagues and my fellow doctors, that they should think of value for many rather than value for money. Thank you very much.
Yes, thank you, Professor. So we'll have a discussion after we finish the presentations. Here we have our president from Medical Working Group, Tomohiko Moriyama. So, Tomohiko, would you like to introduce?
Hi everyone, this is Dr. Tomohiko Moriyama.
Konnichiwa. Konnichiwa.
Konnichiwa. Okay, this is Dr. Tomohiko Moriyama from TEMDEC, Telemedicine Developmental Center of Asia, Kyushu University Hospital. I myself is a gastrointestinal endoscopist, but also have been keen on remote medical education. So thank you for all presenters, and also I really show my appreciation to Dr. Udaya and Pooja for organizing this and a wonderful programs. So I will enjoy. Thank you so much.
Dr. Moriyama, I have spent a couple of months in Kurume. It was more than 25 years ago.
Wow, really?
So Kyushu, when you said, I've been very close to you.
Wow. My high school was placed in Kurume City.
Oh, okay, small world. Small world.
Oh, world is quite small, right?
Yes, small world, really small world.
Yeah, right.
Yes, thank you, Tomohiko. So next presenter is Andy Bleeden. Andy Bleeden works for ECH Alliance as the director for ecosystem and membership, and has developed and built a large network of over 70 plus global digital health ecosystem and membership community of over 850 organizations. He has had a long career in both funding, health and social care going back over 30 years, starting in the mental health field, working with mentally disordered offenders. So Andy, would you please start your presentation?
Thank you very much, and great start to this session. Hearing some, I think, quite brilliant ideas on frugal innovation, which we like to be able to share amongst our network. So fantastic to hear that as a good kickoff for this session. My name's Andy Bleeden, and as has been said, I work with an organisation called the European Connected Health Alliance. It says European. That's a rather an old title now, because we have now expanded and got connections with a community all over the globe, ranging from Canada to Latin America, and as you'll see later on, with India and Australia, and shortly, hopefully by the end of September, an ecosystem in Japan. When I say we're the global connector for digital health, we're a not-for-profit organisation. So let me just share you something about who we are and what we do. And I'm happy to take any questions. I want to try and keep this short because I want to hear more of some of the excellence that's already been talked about so far. You can see my contact details there. We are a not-for-profit organisation. as has been mentioned, I won't go over the details. We have a large community of organisations that have joined us who are mostly, about 95%, themselves government bodies, not-for-profits, hospitals, academic organisations. We use a series of ecosystems to help them to make connections with each other and expand and share good practice, but also to bring together need and solution. That's particularly useful in a rural health setting, as many of our ecosystems also target the area on rural or remote healthcare. And I'll come on to some of those practical examples too. We've built up a network of these ecosystems now, and we'll be shortly launching our 70th ecosystem in Japan, we hope in late September. But what we try and do is encompassed in the bottom left-hand side of your screen, which is around connecting up the dots. Because for all the fantastic ideas we hear about, there's another 1,000 that go unnoticed. And we try to bring our networks together to share and collaborate and expand on the usage of good practice, but also, most importantly, learn from where we've made mistakes. Because by goodness, we made some mistakes in the past with COVID-19, especially in the country where I'm based. I'm based in England, and we're still in the midst of a pandemic, as many of you are. People join the European Connected Health Alliance. Mostly, as I said, they're public bodies. They join for free, which is a great business model if you don't want to get paid. But that's a really good idea to bring those networks together. Within those groups, we also have a large contingency of 230 academic organisations, 120 hospitals, around 100 patient groups, carer groups, another group of about the same size of networks and associations. So you can see the types of organisations that join us, as well as central and regional governments too. And they join for the reasons in front of you. It's an online process. Join us and you expand our network by one, is what I always say to people. And that always counts. I joined the European Connected Health Alliance when it was first set up 10 years ago. And I can remember being in an ecosystem with a network of one. So it was quite a lonely existence, but now we've grown to expand to 70 different ecosystems. You can see the types of organisations that join us here. Some of them you may recognise, some of you may have visited some of them, but they're all very keen to learn as well from the rest of our global partners, especially around frugal innovation, because there's so many dots to connect, we believe, between countries that have expanded and innovated at a scale and pace that some of the other countries are too big, too cumbersome to. So we have a lot to learn. We use our ecosystems to bring permanent multi-stakeholder gatherings together, often tying up both rural and urban areas and bringing them together, but by including all of those players that you see in the circles to your left. We use a philosophy which is around leading with a need. So when we develop an ecosystem, usually with a cluster or a university or hospital, we want to ensure that patients are at the centre of that ecosystem. And those patients are helping to lead with a need by identifying what, for instance, in a field like dementia or diabetes, what the need is for someone who's had a recent diagnosis, and then looking at what good practice might look like from across a region or country, so we can help share practice. Because we know, and I've certainly been a victim of this myself, we work in silos where we don't communicate, we don't share, and even worse, we don't listen. So we use our ecosystems to break down some of those silos by including all the stakeholders in health. And we would encourage you to think about adopting and using this methodology within your own country, within your own region, where possible, and repurposing it to fit. We have ecosystems in very, very large areas. We have ecosystems in very rural, remote areas. I'll give you an example. We have an ecosystem in London, in England, highly populated area. Millions of people live there. We also have an ecosystem in the Highlands and Islands in Scotland, where people live on islands that might take a day or two to get to the local hospital because they're far remote and away. So healthcare there needs to be suitable before COVID to be remote friendly. So people can develop video consultations before the onset of COVID-19. But our ecosystems are also there to actually do something rather than just a talking shop, which is fine for many people, but to actually transform healthcare delivery, to bring about digital transformation in health and social care. But lastly, they're also there to create economic growth, because why would you not see and expect economic growth in one of those areas that's one of the largest spends? So we encourage small businesses, SMEs, to come along with their ideas, their innovations, to shake things up a bit, because that's important. Otherwise, we're back with the same old silos we've had for 10, 20, sometimes 40 years. As I said, our ecosystem network's growing. We'll shortly be opening our ecosystem in Moldova, as I said, in Japan, which I'm looking forward to. But also, we're starting to build networks of ecosystems within countries. And you can see where some of those are in Sri Lanka or in India, but also in Israel, in Wales, in Uruguay, in Argentina. We've started to build connections there because these help us share knowledge from across the globe. And a practical example of that is where we used the innovation that was being adopted in the Highlands and Islands in Scotland, which was remote video consultation. That was rolled out across the whole of Scotland, then across England and Wales. And then people in Australia came to us and said, this is a really fantastic concept. We'd like to do that in Australia. The trouble was that they haven't been connecting the dots, because the people that developed the concept were in fact in Australia. So the idea had been exported across the globe before it was adopted at home. Because quite often, we also suffer from that other dreadful disease, which is not invented here syndrome. And that's a curse to our healthcare delivery and a curse to transformation. So that's an important lesson in terms of how we use a remote idea, but expanded it elsewhere. We also have set up, as part of the work we've done around the pandemic, a whole series of cross-border ecosystems which target different thematic areas, but on a cross-border nature. These are all free to attend and take part in. So I welcome your input and input from participants today. Some of the time zones might be a bit funky, but we're trying to get those people together from Australia and Denmark to lead on our skills for health, using exactly what the previous speaker just said, a concept around training health and social care professionals in the new remote digital age. But we're also developing them around health procurement in areas such as mental health or smart care. We're using this model, we think, in the next 12 months to expand into areas that we've so far not done, such as continents. And I mean continents with a C at the end, not the global sense of continents. But also around areas to do with life science as well, which we think are really important. We've also developed and built up our work around what we call our data arm, which is the Digital Health Society. So all those colleagues who are attending the series of presentations in the next couple of days who are interested in data, I'd invite you to come along and get involved with the Digital Health Society. Again, it's free to become a supporter of that and get involved and learn around, you know, the harnessing the potential for sharing healthcare data, but also on what some of the governance issues and how we mobilize that whole digital health space, not just across Europe, but I think what we're seeing the next year is a more global appeal. I'm going to stop talking now. I welcome you to make a connection with me via the chat function here or via LinkedIn. You've seen my contacts at the beginning. I want to stop talking and start listening to some more great ideas from across Indonesia and Bangladesh. That's enough from me. My name's Andy Bleeden. Thank you very much.
Thank you, Andy. Your presentation is always very impressive. Thank you very much. Now I would like to introduce Dr. Rakesh Verma. Actually, I am also studying healthcare management, and I came to hear his classes, lectures through this research foundation on health administration. Healthcare and hospital administration. So I think our doctors also should be a good manager and an administrator. So Dr. Rakesh Verma. He is CEO of Aeon Med Health and Hospitals, a consulting company specializing in hospital and healthcare quality, accreditation, operations, learning and development systems, performance, and productivity. He is a consultant, speaker, teacher, trainer for hospital and healthcare systems, a veteran from the Army Medical Corps of the Indian Army, and an alumnus of prestigious AFMC, Pune and AIIMS, New Delhi. He is an established healthcare quality and management specialist and has been principal assessor with NABH for over a decade. He specializes in learning systems for healthcare, hospital planning, and designing healthcare HR and risk management in healthcare. He also serves as program director of Research Foundation for Hospital and Healthcare Administration, New Delhi, and editor for International Journal of Research Foundation of Hospital and Health Administration. Sir, Rakesh Verma, sir, please.
I have a small request, Andy. Can you please make us the host? So we were having some technical difficulties, so you were automatically made the host.
Never! Of course, 1 second.
So much.
Okay. Second.
Also, you got the
Go to the participants.
Yeah.
Kathmandu model.
On.
You just make the host.
Does that work?
no.
Yes.
What? Yes.
Yes?
Thank you so
Dr. Uday,
much.
can you see the screen?
Yeah,
Yes.
yeah,
Great. So thank you very much. Thank you, Dr. Uday, and thank you for the kind introduction. And I am delighted to be on this forum to talk about something that I have been, that I practice in my professional practice. So the topic is the scale and scale logistics for resource limited settings. Essentially, how do we manage the enormity of the whole problem of the COVID? Now we are specifically focusing on COVID. However, many of the things that are there applicable for this setting are also applicable to just about any pandemic of this nature. So I guess this can also be extended in application whenever the need arises. So first of all, I come from Delhi, and greetings from India to all of you. This is about me. I think enough has been spoken by Dr. Uday, so I'll not go over it. So my presentation will cover these topics. I will very quickly, briefly in 3 slides cover what is the clinical spectrum that we look at. I'm aware that all of us do have had the opportunity to hear about COVID and its clinical manifestations thousands of times over, but just to put the whole thing in the perspective from which I'll be talking, I need to kind of add this here. We'll look at the public health perspectives, look at the scale and the skill issues that come when you start managing a pandemic of this scale, this size. We'll see what interventions can be done and what should be the overall strategy. And finally, we will look at how to handle the non-COVID care in the hospitals during pandemic, post-pandemic, and possibly for all times to come. Now, this particular aspect, I have given references in the slides from wherever it is applicable. If there is a question or some more details are required, then we could always communicate on that. So having said that, let me begin. This is something that should be familiar to all of us. We know the clinical spectrum of the COVID-19, the 4 phases of it and the 4 stages of it. So without getting into details of this, because clinical aspect is not the domain that I'm addressing specifically. Only important thing to know is that the disease itself is in 2 distinct phases. Initial one is the virus replication phase, followed by a host inflammatory response. And most of the hospitalization issues happen in the host inflammatory response. The response, depending on how the host system works and what is the interaction, we have known about the environment, host, and agent triad of the epidemiology. So it could be a mild respiratory tract disease where it could be called stage 1 in severity scale. It could be a pneumonia, stage 2, severe pneumonia, and the ARDS. So this is one graph that I'll be using for a couple of slides more. The clinical symptoms in the phase 1, in the active viral replication phase, we have fever, dry cough, diarrhea, headaches, and many other symptoms. These are the prominent ones. In the phase 2, the issue is essentially of dyspnea and mild hypoxemia. Phase 3 is multi-organ dysfunction. You have ARDS and many things there. And phase 4 is essentially recovery and the waning of the accelerated host inflammatory response. So with these symptoms, these are the signs that come with it, and they all can be elicited in clinical examination or tested, or you can have the imaging modalities telling you this. So this is about the signs and the therapies. We know about it, but just that I needed to just show it once so that we get the whole thing in perspective. Now, having known this, from the public health point of view, these are the numbers. These are estimates, approximate figures, and in percentage terms. Now, please remember, what looks very small in percentage terms, in absolute numbers, it can actually be a very large figure, depending on what size of population is affected. So, the majority of the cases continue to be the asymptomatics who will not present with any clinical symptom, but if you test them, they might be positive. Majority of them belong to this category. Another big group is the people with mild disease, where the need to really come to the hospital may not be there at all. Severe disease and eventually multi-organ failure and leading to death is a very small numbers compared to the total, very small percentage compared to the overall figures. Now, absolute numbers can be a very different story altogether. As we have seen in India, the death figures or the severe disease figures, even though the percentage remained what I am showing here, but the absolute numbers were enough to overwhelm the system on multiple counts, on multiple occasions. So from the public health perspective, if you look at the rates of hospitalization, again in percentage terms, for the various age groups, you will see that the biggest chunk comes from the young adult population. And in the elderly groups, higher the age, the higher is the percentage of hospitalization, a percentage of the population is getting into the hospital. But please remember, the population in the age group above 75 will, in any case, will be a smaller number of the total population. So the number of hospitalizations may not be very many, even though in percentage terms, percentage in reference to that particular population age group will be a different story. So here again, most of the hospitalization comes from these adult, young adult groups from 18 to about 60, 65 years of age. And this is the problem that needs to be addressed at the hospital level. So for our purpose of discussion today, and since I'm addressing this requirement or the issue of scale and skill, I have divided this whole management in two groups. One is something that needs to be done in the community, and the second is something that needs to be done in the hospital. And logically so, the phase 3 will mostly fall in the hospital, and it will require acute care in the acute care settings. In the community, the public health perspective continues to be test, isolate, and treat. So going further, these are the skill and scale issues that we have at the community level. So in the testing is one of the important step in managing the situation or the managing COVID-19, and test logistics is a big challenge. We remember from our time, from India, when the pandemic started last year, testing was a huge challenge. Of course, many other things were a challenge, but testing was a huge challenge. The numbers were, the testing facilities were not available, the technology was not available, people trained to operate those systems were not available. the cost of setting up such facilities was prohibitive to begin with. And of course, because these required RT-PCR and the facilities were not available, so reach was one major issue at the level of community. The next is the requirement of quarantine, and in the initial stages, I think all countries did it. We also did it. We ended up quarantining anybody who was testing positive and all the contacts in the centers that were created for the purpose of quarantine. And creating such centers is a logistic exercise that needs to be undertaken at a much larger scale, because you have a large number that needs to be put in the quarantine. Again, the problem of scale here, the number of facilities needed to be built. So you used the stadias or any large accommodation, schools, airport hangars have been used. So lots of places can be used. Staffing such facility is a far bigger issue. It is possibly easy to create 1,000 beds, putting money to buy the bed logistics, linen and things like that. But getting staff to man them is a different ball game altogether. So staffing is a big challenge, especially when you have overall shortage of the healthcare providers. And then implementing quarantine where people trying to escape from getting affected, trying to avoid quarantining themselves. So this is another issue that comes up when you look at the community side of the story. Home treatment came about, and it continues to be the important intervention at the level of community. The problem here or the issues here are the availability of the drugs that are prescribed and the safety issues that come with the administration of those drugs. So wherever you have a situation where supervision is required or some monitoring is required, then obviously these things cannot be recommended in a home setting. And then monitoring those patients who are under home care in lots of parts of in the world, and it also happened in Delhi in the first phase last year in 2020. We had the government health departments keeping in touch with the patients who were under home treatment, who were quarantined at home or who were isolated at home, giving them phone calls on a regular basis. But I'm aware that this was a huge logistic exercise, and it was not possible. It may not be possible for everyone to really do this. In fact, at a much larger scale, it is something that is very difficult to implement and ensure the quality of whatever monitoring that is planned with this. And finally, there are social issues. So you have fear, you have stigma, you have social media, coming up with a whole lot of interventions. We saw, in fact, I am personally aware of such instances where I think around the month of April this year, dexamethasone was a recommended drug for handling the host inflammatory response in the phase 3 and phase 4 of the disease. But this came about as a wonder drug, and everyone thought that the dexamethasone can be consumed. So people consumed in quantities, even in the phase 1, in the active virus replication phase, and that led to a different kind of issues. So you have social media coming up with all kinds of misinformation that needs to be addressed. And in India, especially, I can talk about Delhi. There were, the government guidelines and the rules on how and what can be put on social media. So this is an issue that needs to be addressed at the level of community. Now, in the hospital, the game is totally different, because there you have to deal with the accelerated inflammatory response. So the scale of intensive care provision is important. So what facilities can you provide? Dr. Dhananjay talked about creating more ICU beds, creating more pipe supply of oxygen, and training more staff. So these are the issues that are required to be addressed. And hospitals cannot reach everywhere. Our countries, the scale, the spread, and the populations are such that the geographical limitations itself will ensure that you can't reach everywhere. So therefore, this continues to be a big challenge for providing care. In the hospitals, creating isolation facilities, see, if you look at the Western recommendations, it simply says 1 room, 1 patient. this is just not possible in the kind of settings that we have. So create isolation facility is a huge challenge. PPE was a huge challenge and it continues to be a huge challenge, and staffing is a problem. In fact, I'm aware people doing 12-hour duty, 24 hours duty, just because there is nobody to relieve people from the duties, and people have to get into that kind of a work mode. Availability of drugs in the hospitals. So any drug that gets touted as the treatment, the drug simply vanishes from the hospital, from the market. For two reasons. One, people hoard, do black marketing and those kind of things. And second, the requirement, pops up. In fact, in one situation where I saw a peripheral hospital prescribing remdesivir to a patient, knowing fully well, the doctor also knew, everyone knew that this particular drug is controlled, cannot be just prescribed just like that. Yet it was prescribed. Why? Because the pressure on the health system, on the doctor itself was so much, the patients and their families will chase them to prescribe this. So they end up, in many instances, possibly over-prescribing. And of course, monitoring in the hospital is an issue because you always have a staff limitations. And the infection control in the hospital, where you are concentrating large number of COVID-19 patients, infection control is something that needs to be addressed. So what do we do? So these are the possible interventions, and almost all countries, all governments have done it to varying degree of success. As Dr. Dharanja also pointed out, vaccination continues to be the most efficient and effective intervention available as of now. But till the time we reach there, because there are difficulties in reaching there, getting everyone to vaccinated. So we have to address the issue of awareness, teaching people, enforcing masking and hand hygiene, and many other interventions that are being promoted at the level of community. We need to look at the containment zones. Everyone is doing it. I think in India also, that is what the recommendation is. But again, this has the problems of law and order. You need to police the areas. You need to implement the kind of restrictions that you want to put on people, doing the contact tracing, and it is not easy. I mean, I have been part of one such exercise on a very small scale, and it is a Herculean task to really do this. People, obviously, for many reasons, may not cooperate, and then you end up, losing the whole the purpose of doing this. Vaccination, we have already stated, and infection control in the community. Again, it rests on the testing and isolating, and then the attendant problems of that. In the hospitals, the interventions available in terms of skills that we need to train and upgrade. I have realized that online training is something that has really boomed in this scenario. The platforms have also developed well. I mean, you could do a session of this kind maybe 2 years back, but now you have the kind of the kind of platforms available where you could do this. I am personally involved in a lot of training activities online. So I have realized that this is something that can really scale up your training issues, especially where there is a limited role of skill enhancement. If something has to be a hands-on training, then obviously you need someone to demonstrate, hold, and possibly do an in-person session. But large quantum of training, close to 80–90% of training, can be just shifted online and scaled up drastically, almost magically. Staffing again is an issue, and it needs to be addressed. So people have diverted staff. People have stopped non-COVID services, and the staff has been diverted to COVID care. So those things have been there. Protocol is a problem. The disease management itself is in evolution. So every new research comes up with a new solution. And therefore, that new solution to be taught to the people who are the frontline care providers is a requirement. So how to percolate this new information that comes up from research to the person who's actually treating the patient on ground is something that needs to be addressed. The medical logistics and the supply chain is a big problem. When there was a total lockdown, that also disrupted the supply chains of the medical logistics. Of course, in the subsequent iterations or versions of lockdowns, the governments also learned, and then the logistics or the supply chains were kept out of it, and that is how it improved slowly. Costs is an issue, and if you are looking at the rural setting, if you are looking at resource limitations, the cost is something that needs to be, that becomes a prohibitive aspect of the entire situation. In fact, the hospitals which are operating all by themselves, they really find it tough to manage the drugs, the PPE costs, and that has led to many innovations. I'll cover a few of them here. PPE reuse was one where you could, reuse PPE by putting it through a process which will make it safe for reuse, even though the item itself is a single-use item, but you could do that. Many solutions are now available. In the infection control, screening, triage, and the universal source control continues to be the hallmark or continues to be the mainstay in the hospital setting. And I'll cover in one slide very briefly what to be done. So in the community, the solution lies in outreach. We need to go out to community, tell everyone in demand compliance to the norms of hygiene, norms of masking, norms of social distancing. I know it is difficult, but then at a resource limited situation, we don't seem to have very many options here. Of course, vaccination is there, but then till the time vaccination gets us to a situation where this may not be necessary, we are some time away from that point. And in the hospital, for all critical care, for all hospital base, the idea will always be to concentrate resources. You can't open up ICUs in multiple places because you will not have staff available to do that. So intensive care and critical care needs to be concentrated, and community care needs to be spread out in the community. That is how it needs to be done. Ensuring supply chains, yes, I think the governments have intervened in most places. So the drugs are being regulated, the antivirals are being regulated, and the oxygen also till some point, till some time back was being regulated in India as well. Oxygen supply chain is an important part. If you're dependent on LMO, that is liquid medical oxygen, then it needs to be transported. If you have generation plants, then it makes it a little easier. There is a model called the Nandurbar model. It's a district in Maharashtra state in India. I'll in one slide, two words, I'll cover that. Supply chain will also be required for expanding beds and alternative care sites. But please remember, any critical care or hospital-based care needs to be concentrated, brought together so that you have the number of staff that you have is able to manage it. You open 10 hospitals in 10 different places in the same district, you will have difficulty manning them. It is not possible because you may not have, there will not be enough healthcare providers. And controlling panic among the public is very, very important. Every positive patient running to the hospital for getting admitted is not a good idea. This happened in the first phase. This also happened in second phases in many places in our country as well. I'm sure it is happening in other places as well. So controlling panic and regulating inflow of patients into the hospital is important, and that is where triage comes in. So this is just one slide that shows what all can be done. So and these are common sense, most touted interventions. I'm not going to read the slide, but it is kind of self-explanatory. In the hospital setting, it is important to build a barrier between the hospital and the community. So when it comes to patients, you need to do a triage. This could be a telehealth triage based on app or a phone or a telemedicine or something similar. Then you allow the patients to come in. For anybody who is visiting, or staff needs to go through a screening process in the hospital so that you protect the hospital from getting the infections from outside. Universal source control essentially means masking and using PPE kits for the healthcare providers, targeted testing processes for exposed healthcare professionals. How do you place patients in the hospital using PPE kits, aerosol generating procedures, environmental infection control, and airborne infection isolation rooms? These are the various modalities or various methods available we can use many of them, and they need not, all of them need not be used in one hospital. So the idea is to list them here so that one can figure out and take what is possible. The left side of the slide is important, where you build a checkpoint or a check post of triage and screening. And now about the Nandurbar model, it's a district, a tribal district, a predominantly rural district in the state of Maharashtra. What they did and how they did it successfully in phase 2, especially so in the second phase, the second wave, as it is called in India here, in the month of April, May, part of June, anticipating the requirement and preparing well. So they being, even despite being a rural state, a rural district, it had the oxygen plants which were sufficient, and they planned it well. That's how it worked. Innovations regarding the real-time dashboards on updates. So what is the current community status of the infection is something that needs to be known both through the administration and to the hospital people, so that they can take steps. And I will come to the non-COVID care framework, where this particular aspect becomes really important. The Nandurbar district also employed what was called the oxygen nurses, because the panic prompted people to hoard oxygen cylinders, and that has been regulated by the oxygen. Anything? Okay, so the panic prompted people to hoard oxygen cylinders, to get into the hospitals to get oxygen, even though they may not need it. So therefore, the oxygen nurses was an idea. These nurses were essentially regulating the use of oxygen and optimizing the use of oxygen. And this is a story which is now emerging. We have various strains, variants. So we have a Delta variant. This is important for us to know at the community level, that the Delta variant comes with a R0 value of 5 to 8, which means one index case will produce 5 to 8 patients, which is something equivalent to a chickenpox R0. It is less than mumps and measles. It is more than the original coronavirus, and it is something equivalent to chickenpox. So this shows the infectivity or the transmissibility of the virus in the community. And that is where the personal level intervention becomes important. And now very quickly, the end of the presentation, I'm going to talk about the non-COVID clinical care framework. This slide, I think the organizers can make it available to everyone. I'll share the presentation because if I read through, it is going to take time, but just to know that we need to be, this framework is dependent on 3 key considerations. One is readiness to rapidly detect and respond to surge in cases, and the dashboard that I talked about in previous slide is ending here. Keeping track on a daily basis. How many cases tested positive yesterday in my district, in my locality, in my region, not at the national level, because the response will be local. So therefore, local count known is important. And then when you start elective procedures for elective patients for like surgery, cardiology, and many other specialties, non-COVID care, you need to create these resources, obviously, because without them, it is not possible. The second key consideration is to provide care in the safest way possible. So encourage use of telemedicine, telehealth, visiting hospitals only when it becomes absolutely essential, and following the infection prevention and control practices. And the third key consideration is that the services may need to be expanded gradually in a post-pandemic phase. You cannot just open the hospitals without being prepared for it. And local epidemiology should guide coming back to so-called new normal. So these are the 3 tables where you have the community transmission at 3 levels: substantial transmission, moderate or a minimal transmission, and then you have the likelihood of patient harm. So if patient has a non-COVID problem, what is the probability that the patient will get harmed because of that non-COVID problem? For example, a fracture. If a patient has a fracture, how serious is that, and whether it is, if you don't do, what happens? So if the likelihood of harm to a patient due to a non-COVID problem is high, then the 3 options available are here. So if there is a substantial community transmission of COVID-19 virus, then you have to look at providing care to this patient in a non-COVID hospital, which essentially means that you have to have some facility which is non-COVID. Then if there is a moderate transmission in the community, then this option. And if you have minimal transmission, then of course, the care can be given with the usual infection control measures. The second is the likelihood is less, and then the options are here. And the third one is that you have the patient harm is unlikely. So the patient has a non-COVID problem. For example, a stable patient on stable hypertension, diabetes patient on medication, he has to come to the hospital for monitoring. So the patient is stable on medication. So the potential for harm is less, and therefore you could intervene in a different way. This I have taken, or this is the framework that is recommended by the CDC, and it is also available. I have given the reference here. With this, I finish my presentation. If there are questions, I'll be happy to answer.
Okay, thank you, Dr. Rakesh. It was very nice and elaborative presentation. We'll have discussion at the end. So next presenter is Dr. Muhammad Kamruddin Khan. He is from Department of Community Medicine, Mymensingh Medical College. He is assistant professor in community medicine. Dr. Khan, please. You are muted, sir.
Thank you, Dr. Uday Koirala, for giving me a chance to present from your session. And welcome everybody to my presentation on tracking side effects of COVID-19 vaccines in Mymensingh district of Bangladesh. The coronavirus disease 2019 has turned into a worldwide human tragedy and economic devastation. There had an intensive search for an effective and safe vaccine to prevent COVID-19. A vaccine has the power to generate herd immunity in the communities, which will reduce the incidence of disease, block transmission, and reduce the social and economic burden of the disease. Bangladesh started nationwide COVID-19 vaccination on 27 January 2021 with the vaccines invented by the Oxford AstraZeneca and produced by Serum Institute of India. Though many people want to protect themselves against coronavirus infection, they are ambivalent regarding corona vaccines because they also fear possible side effects from vaccination. Many of them, including even the physicians, are just waiting and observing prior to take their own vaccines. They have doubts as to whether the vaccines are actually safe and whether possible side effects have been adequately studied or not. This study was designed for tracking the side effects after first and second dose of Oxford AstraZeneca vaccines used in Mymensingh district of Bangladesh. The results of the study will enrich the data on risk and side effects of vaccines for COVID-19. The study results will help physicians, manufacturer, and policymaker to weigh benefits and risk of the vaccination drive in Bangladesh and to continue the vaccination program covering highest possible number of people of the country. The general objective of the study was to determine the side effects of COVID-19 vaccine in Mymensingh district of Bangladesh, and the specific objectives were to find out the socio-demographic characteristics of the vaccine recipients of Mymensingh district of Bangladesh, to determine the side effects after first and second dose of COVID-19 vaccine. This cross-sectional descriptive type of observational study was conducted in Mymensingh Medical College of Bangladesh from February 2021 to June 2021 among the personnel of different occupations of both sexes taking 2 doses of COVID-19 vaccine during the study period from any vaccination center of Mymensingh district. According to the 2011 Bangladesh census, Mymensingh district had a population of 5,11,272 people. Using Reosoft, considering this population at 95% confidence interval with 5% acceptable margin of error, calculated sample size was 385, but due to pandemic and lockdown situation, ultimately it was possible to enroll 293 personnel having both doses of the Oxford AstraZeneca vaccine. Data were collected by face-to-face interview of the selected vaccine recipients using a semi-structured questionnaire. Collected data were input into SPSS version 26.0. Qualitative variables were summarized by percentage and quantitative variables were summarized by mean and standard deviation. Necessary bivariate and multivariate analysis were done. There was no physical or psychological risk associated with this study. Informed written consent of the participants was taken prior to interview. Ethical clearance was obtained from Institutional Review Board of Mymensingh Medical College, Bangladesh. The mean age of the vaccine recipients was 40.3 years with a standard deviation of 8.7 years, and the maximum vaccine recipients were between the age of 21 to 50 years. 54.3% vaccine recipients were female. Among the vaccine recipients, 53.2% were government service holder, others were teacher, non-government service holder, banker, media worker, and housewife. 86% of the vaccine recipients were from urban area. 10.2% of the vaccine recipients were smoker. And 23.2% of the vaccine recipient had different type of comorbidities. Among the comorbidities, hypertension, asthma or chronic obstructive pulmonary diseases, and diabetes mellitus was in the top of the list. And after first dose, 74.1% of the vaccine recipient has different type of side effects, and 55.3% of the vaccine recipients has side effect after second dose. Among the side effects, pain in the injection site, fever and headache were more common. Others were loose motion, nausea, joint pain, rash, cough, fainting after injection, body ache and intense weakness. To manage the side effects, 29.4% patients, 4% vaccine recipients used medicine after first dose and 8.5% used medicine after second dose. The prevalence of side effect was more in female in case of both first dose and second dose. And the side effects were more prevalent in comparatively younger age group than older age group. Mean age of the vaccine recipients was 40.3 years, which was obviously higher than the average age of the general population of Bangladesh. Among the vaccine recipient, female was more than male. The early phase of vaccination program in Bangladesh was intended for the frontline health workers and some other frontline workers. The high number of female might be related to the reason that in our health system, female workforce like female doctors and nurses are higher than male. Food and Drug Administration of Philippines also found higher number of female among the vaccine recipients in early phase. 23.2% of the vaccine recipient had different type of comorbidities. A study in United Kingdom found comorbidities in 25.6% of the participants, which was a bit higher than this study. The study results revealed that 74.1% vaccine recipients had side effects after first dose, which was lower than the expected. The phase 2 and 3 trial of Oxford AstraZeneca vaccine reported adverse effects in 88% of the vaccine recipients. On the other hand, 55.3% vaccine recipients had side effects on second dose. First dose caused side effect more than second dose, and the difference was statistically highly significant. Inversely, the United Kingdom study found side effects significantly more prevalent after second dose than first dose of the Pfizer-BioNTech vaccine. The side effects of first and second dose of AstraZeneca vaccine were prevalent higher in younger age group than the older. Similarly, in the study of United Kingdom, side effects were significantly more prevalent in people aged 55 years or younger than those older than 55 years. In this study, pain in the injection site was found in 58.7% vaccine recipients after first dose and in 48.5% after second dose. FDA of Philippines reported pain in the injection site of 24.2% recipient of the viral vector vaccine. In this study, fever was found prevalent in 33.4% after first dose and in 20.8% after second dose. FDA of Philippines found fever in 46.2% of the vaccine recipient, which was much higher than this study. 10.6% vaccine recipients had diarrhea after first dose and 8.9% after second dose. The United Kingdom study found diarrhea in 2.2% of the Oxford AstraZeneca vaccine recipients. First dose caused nausea in 9.6% and second dose in 5.5% vaccine recipients, while the UK study reported nausea in 5.7%. Joint pain was prevalent in 8.2% after first dose and in 5.1% after second dose, whereas the United Kingdom study found joint pain in 11.5%. Now the conclusion. The study results revealed that 74.1% vaccine recipients had side effects after first dose, while 55.3% had side effects after second dose of Oxford AstraZeneca vaccine. Commonly experienced side effects were pain in the injection site, fever, headache, diarrhea, and joint pain. Most of the people tolerated these side effects and did not use any medicine. There was no serious side effects like seizures, abscess, sepsis, bleeding from injection site, toxic shock syndrome, thrombocytopenia, or anaphylaxis. Further multicentric large-scale prospective study is recommended to explore long-term side effects of the Oxford AstraZeneca vaccines. I would like to express my gratitude to the Authority of Planning, Monitoring and Research, Directorate General of Health Services, Bangladesh, for providing me fund for conducting the research. Thank you everybody for patience hearing.
Thank you, Dr. Khan. Our next presenter is Dr. Dennis Batangan. He is MD, MSc, Heidelberg. He is a health social science researcher and public health specialist from the Institute of Philippine Culture, School of Social Sciences, Ateneo de Manila University. His academic degrees include the following: BS Psychology from the University of the Philippines, Diliman Doctor of Medicine from the University of the Philippines, Manila, and an MSc from Community Health for Developing Countries from University of Heidelberg in Germany. So I would like to welcome Dr. Dennis, please.
Yes, thank you very much, Dr. Daya. So thanks again for the invitation, no, for this conference, which we have been sharing and joining us for several years now. So the presentation for this afternoon will be on local health information systems as integrating platforms for COVID-19 responses in the Philippines. Now, I will be sharing this as part of one of the projects that we're doing at the Ateneo de Manila University, and as part of my work with the UK Foreign Commonwealth Development Office Better Health Program for Southeast Asia. So the objectives of the presentation would be threefold. So the third objective will be in the next slide. So first is provide an overview of the Philippine digital health landscape as the context for local health information systems, and present updates on a local health information exchange model that was used as COVID-19 response platform. The asterisk there refers to actually to a application or a software tool that we have developed that has been granted utility model registration and patent pending in the Philippines. On the right side of the screen, you'll see a map of the Philippines, which just shows where we are, or some demographic data, which the Philippines is a country, a part of the ASEAN, or Association of Southeast Asian Nations. It has a population of 110 million approximately as of May 2021. It's an archipelago with 7,641 islands, and over an area spread out on 300,000 square kilometers. The third objective, which I put in a separate slide, is relating to a project of the Better Health Program for Southeast Asia under the UK FCDO, which I will describe as an electronic vulnerability profiling tool for prioritization for COVID-19 vaccination and other social protection services, which we are piloting in 2 cities in the Philippines. To start off with the context in the Philippines, we just recently signed in 2019 the Universal Healthcare Law, and what I'd like to highlight in this slide is how actually universal healthcare is related to the national development goals, and how e-health is seen as a major pillar of governance in the implementation of universal healthcare. So this slide is actually borrowed from the Department of Health. Another slide to provide the context in the Philippines. This is coming from the Philippine Health Insurance Corporation. Shows the Philippine digital health infrastructure issues and EMR use. It shows how many facilities, particularly government facilities, have access or inadequacy of access to IT infrastructure and services. And you'll see that actually we still have a lot more to improve on or to work on in terms of IT infrastructure and EMR use in the Philippines. This is another slide borrowed from the Ministry of Health, the Department of Health in the Philippines, which is describing in diagrammatic form how the healthcare provider network in the Philippines is planned to be implemented under the universal healthcare. So under this particular diagram, you'll see that there is some kind of network where patients are referred to private or public facilities, and eventually, if needed, also referred to what we call the apex hospitals. What I'd like to highlight here is that these different processes that are envisioned in our universal healthcare, including the building blocks of the health system that are shown in the left side, are dependent actually on the IT infrastructure and the e-health program that the country needs to provide to be able to achieve this particular implementation, of course, monitoring of this particular network. Another major reform of the universal healthcare in the Philippines is actually what we call the decentralization or further decentralization of services to the provinces and cities through what we call the province and citywide health systems. And this is where I would like to locate the development of local health information exchange. The Philippines actually adopted in around 2013, 2014, the Philippine Health Information Exchange approach or framework in terms of implementing the national e-health program in the Philippines. But in recent years, no, because of the universal healthcare, because of the decentralization, the evolution of services, we are moving towards a what we call a local health information exchange context, meaning provinces and cities will have now to develop some form of a local exchange that can now link to the national exchange. But as this is being developed, we are also going through several reforms and changes in the country. Particularly, we have to incorporate now the national ID system. We have to be more conscious of data privacy issues because of the Data Privacy Act. There is a national interagency task force on COVID-19, which actually is issuing out different types of policies and guidelines related to e-health. And of course, the universal healthcare issuances, which now have to be incorporated in these exchanges that are evolving in our local settings. Now, moving on to the local health information exchange setup that I would like to describe, we have actually prototyped this exchange through a series of projects under the IHATID System 2.0. And under that prototyping of a local health information exchange that we have done in 2019, we were asked to develop a expanded prototype for a city and a province, which we are now doing in support of the universal healthcare. So what essentially happens is that the interoperable prototype that we have developed becomes the background technology to develop another prototype for another local government unit, but with customized functionalities specific to the needs of that particular locality. This particular approach that we're doing now has been supported, of course, by the Department of Science and Technology in the Philippines, and the work that we're doing is also supported by the university, the Ateneo de Manila University. Just a brief description of these prototypes. The first prototype on municipal level interoperable layer called the SMILIS, for Pulilan, Bulacan, for an municipality, or SMILIS is the Smarter and Integrated Local Health Information System, looks into actually the issuance of medical certificates. So what the diagram shows is that we had to integrate actually several registries so that if a citizen of that particular municipality requests for a medical certificate, the processing can be done by validating the records of that particular applicant through the different databases that we have identified that are relevant to the issuance of medical certificate. And if that particular applicant satisfies all the requirements, then the medical certificate can be issued at the point when it was requested. So that will actually, when we looked at the process, the usual process without this interoperable platform will take around 5 visits to the municipal site, but with this platform that can be reduced to 1 visit. The other use case that we are doing, the interoperable platform, is on a city level, wherein the use case is also on the issuance of a medical certificate or health certificate, and also some kind of a referral to higher level facilities, which has now evolved to be part of a COVID response in that particular city. I just put the dotted line around that particular diagram because it's still in development. So what essentially we are doing is, again, integrating several registries so that a certain patient who asks for a certain service, for example, a health certificate, can be navigated from the health center to other facilities, even referrals, using the interoperable platform in that particular city. But as we know, a city has a more complicated setup compared to a municipality because it has districts, it has also a bigger population to deal with. This is how it looks like now, in terms of the current evolving prototype as it serves the COVID-19 requirements of a particular city. So what you have here is actually the dashboard for that interoperable platform, wherein you will see the facilities, no, per village. This has a count of the facilities per village and the number of beds available in these facilities, which can be drilled down to a particular village or for the entire city. So it's now possible to actually check the number of available beds in all the facilities in a particular city as a form of, as an indicator of the utilization of the hospital beds in response to COVID, no, and of course the other and other illnesses in that particular city. I would like to move now, no, to the other pilot project that we're doing, which is focused mainly on NCD or non-communicable diseases, which is part of the UK FCDO project in the Philippines, no. It's actually called a MUPLUMP or multi-program local mapping tool. And what you see on the top is actually how the dashboard looks like. So it's an electronic mapping tool, recording reporting tool that we have developed for two cities in the Philippines to sort of have a electronic version of the reporting system and reporting process of the Ministry of Health, no, regarding NCDs in the Philippines. And what you see there actually is a dashboard which shows actually the number of patients per facility, and of course the facilities, including their targets in terms of selected non-communicable diseases. So that gives them a sense of where they are in the implementation of their respective non-communicable disease program. So it has a dashboard, it has a patient registry, which includes list of patients, including facility visits and treatment management records, and reports, no, which actually is shown actually in the dashboard, which shows you the target client list, formatted required reports for specific programs and aggregate reports. I'd like to highlight, no, what you see at the bottom is that within this particular application tool, which we actually develop a vulnerability profiling and feeder this for COVID-19 vaccination prioritization. What happens is that we can actually extract from the registries and identify the more vulnerable members of the population who could now be identified or could be prioritized for vaccination and other social services. So what you see here at the bottom is actually color coding, so that we will know who the patients who have actually more morbidities or comorbidities or vulnerabilities who should be prioritized for COVID-19 vaccination and other social protection services. So I think that's it for me. Thank you very much, no, for your time and for listening to this presentation. I shared with you two evolving models of local health information exchanges in the Philippines being used as platform for COVID-19 responses in the Philippines. I'd be glad to take on questions after if there are any. Thank you very much and good day, everyone.
Thank you, Dr. Dennis. It was again a very good and elaborative presentation. Excellent. So next presenter is Dr. Shreyas. He graduated from Nepal Medical College. He worked with FECT Nepal from January, and now he's working in our one of the rural healthcare center situated in Magdi. So Dr. Shreyas, please.
Hello, Dr. Can you hear me?
Yes, yes. Full screen. Can you do the full screen?
Okay. Okay. Thank you, Dr. Uday, for giving me this opportunity to share my experience while working in a rural setting here in Nepal. So I have been working in Nagi. It is a rural village here in Nepal, and I will give you a brief demography of the area. So Nagi is a rural health center which is located at an altitude of 2260 meters from sea level. So it is quite in a high altitude. The nearest city is Beni, which is at an altitude of 900 meters. So you can imagine its ruralness. So it takes about 3 hours to get up into the village. So the total population of the village is 450, and they live in a household of 170 houses. And the population of the surrounding village is around 1,000 individuals. So giving a brief description about our center, there are 1 doctors, 1 CMA and 2 ONAMI, which are the basic level of healthcare that we provide here in Nepal. And we have 1 radiographer and 1 lab assistant here. For our inpatient, we have facility of 1 oxygen bed with an oxygen concentrator. We also provide services such as X-ray, USG, and an ECG service. In our lab, we have basic lab investigations such as hemoglobin, TLC, DLC, RBS, ESR, CRP. We provide lipid profile and a basic urine RME. We provide 24-hour emergency service, and during this COVID pandemic, we provide PPE to all our medical personnel. So this is my brief report about how we have been dealing with COVID in our first wave and the second wave. So in our first wave in 2020, there was only 1 positive case of COVID, and in the second wave in 2021, we have 2 cases. So the first case was detected by PCR, and second case we detected it by RD kit. So in the first wave, we didn't perform any mass screening, and we have improved that by providing a mass screening test for the individuals of the village. We have provided 70 PCRs, and we have done 25 RD kits. So for the so in the contact tracing, we have done 2 contact tracing for the single case we have detected, and in the second wave we have done 6 contact tracing. So currently there is RDT kit present there, and there was no RDT kit present during the first wave. Also, we have medicines such as dexamethasone. We have an oxygen concentrator now, which was not present in the previous wave. So the number of patients we had to admit is 0 in both of these waves. So this is our center. So working in a rural healthcare center, there are many advantages for COVID. So there we have been provided good support from local government. And also the remoteness of the village is a major factor against COVID, because the people are always living physically distant from one another. And the population size, as I have already said, is very low, and it is a very manageable population size. Also, there is availability of telemedicine around the clock, which helps with proper communication with higher centers. So these are the measures we are taking to fight against COVID-19 in our village. So we have provided, so the local government has provided with the vaccination program. We have done vaccination with Covishield. We have provided Verosil, and also recently with J&J. So we have been providing RDT testing to all the suspected individuals free of cost. The local government has supported us with this. And also someone who is traveling from a urban area, they are also being RDT tested free of cost. The local government has also provided us with basic medications such as paracetamol, vitamin A, zinc, vitamin D, and calcium tablets, and also cough suppression and ORS. We are giving away masks and sanitizer, which are also provided by the authority. The schools in the area have been closed due to the second wave of the COVID pandemic. Also, Nepal government has provided us with a 1-month free call and SMS services for both medical personnel and teachers and students. So also we have banned the festivals and social gathering which are occurring in the village. So these are the drawbacks that I have been facing while working in this center. So it is really challenging to bring oxygen cylinders up and down into the village. The PCR test that we are doing takes 4 days for the reports to arrive, so it is a real hassle. And also the most important thing is the lack of public awareness among the people of the village. And people are reluctant to stay in isolation centers and are reluctant to come and get tested for COVID. And due to the remoteness of the area, the tertiary care centers are difficult to reach on time. Also, the vaccination drive is poor and there are frequent roadblocks during monsoon, and there is lack of law enforcement officers in the area. So these are the plans for the future that we have been working on to raise the level of awareness among general public, to making rural centers self-sustainable, to reduce the burden of disease in tertiary centers, adding the number of oxygen concentrators, adding more RDT kits, and also preparing a dedicated vehicle for transportation of COVID patients during emergency, while providing the driver with a PPE set, an oxygen cylinder and a saturation probe. We are planning to do mass screening for the people of the village, which will enable us to concentrate on early diagnosis and treatment. Also, we have been coordinating with higher centers for tests like D-dimers, CECT, and also for the availability of ICU beds. And also we are looking forward for national and international donors to support our cause. So this is one of the mass screening programs that we have done recently in the area. So also this is the condition of most of the rural areas of Nepal. We have frequent landslides in the area, and it is a real logistical challenge. So to combat this, we have provided the hospital with RDT kits, which are very convenient to use. So to conclude my presentation, I am concluding that having worked in a rural setting with many economic and resource constraints, we have been so far able to contain the spread of COVID. Saying this, we must strengthen our capacity to contain the disease from possible future outbreaks. Thank you. Thank you, Dr. Uday.
Okay, thank you, Dr. Shreyas. We had one presenter, Dr. KD, because he's of his busy schedule, so he will not be presenting in this session. We are already running out of time, but now we are going to 0 hour. So if someone want to have some discussion, introduction, or any questions, please, we can continue. So is there any question or comment or any suggestions?
Dr. Uday, it has been a very interesting session with many different presentations, which are all very thought-provoking. And it's a difficult situation for everyone, and everyone is tackling it in their own ways. So it's good to know how others are reacting, how they are resorting to finding solutions for their difficulties. Very good.
Yes, thank you, sir. So, is Professor Sheila Zone present in Sankara Nethralaya, Chennai? Sankara Nethralaya, Chennai, Professor Sheila Zone, are you there? So finally, I think we will say goodbye one by one. I would like to invite Dr. Dennis. Will you say please goodbye to all? You are muted, sir.
Yeah, thank you very much, Dr. Daya, and to our colleagues who have attended this session. I agree with Dr. Dharma that the presentations are thought-provoking, and it allows us to share what's happening in our respective countries, and to also share that solidarity of being able to share our knowledge, in terms of what can we do and what we are doing to be able to address this pandemic and to be able to cope with the challenges we're facing at the moment. So thanks everyone, and have a good day, and stay safe and stay well.
Yeah, thank you, Dr. Dennis. Professor Sheila Zone is here from Sankara Netralaya. Will you please say some words and say goodbye, ma'am?
I was very happy to participate in this program and learn more about the conditions in your place. I think the COVID pandemic in each country may be having some similar features, but varies from place to place. And so many precautions and so many things we have to follow. It was a very good session. Thank you very much.
Thank you, ma'am. Dr. Idris Sulaiman from Indonesia. Actually, he's in Australia. Will you say some words and say goodbye?
Sorry, beg your pardon. Thank you very much for the opportunity to participate in this. I share all the feelings that this is a very major sharing exercise, and hope we can be doing this offline as well. And thank you very much, Dr. Udaya, for coordinating this. I hope that we could share the presentation on our website so that it can work together with the YouTube facility that you have been always putting up. That's very, very good. But I think it's good to have the presentations as well being put up online. So thank you very much, everyone. I hope next time we can have more effective sharing just like this one. Thank you so much.
Thank you, Dr. Idris. Here is Dr. Rajkumar Dangal. He's also working in one of the rural healthcare setting. Dr. Rajkumar, will you say goodbye to all? Dr. Rajkumar from Dolakha. Okay, Dr. Tomohiko Moriyama, will you please conclude the session?
I really enjoyed this session. This kind of a conference, sharing knowledge and information with colleagues is quite important to overcome this global crisis. So then now we have a vaccination, and the spread of the situation is a bit different among countries, but we really have the goal of this pandemic, I suppose. So I really hope all you guys stay safe and stay healthy. Sometimes staying at home is sometimes a trouble, but now we have an Olympic Games. We can enjoy and cheer the athletes in our homes. So let's stay safe and see you again.
Yeah, thank you. So we'll say goodbye to everyone. Thank you. It was very nice and interesting presentation. Thank you all.
Thank you.
Arigato gozaimasu, Sensei. Okay, bye-bye.
Arigato gozaimasu. Thank you so much.
Bye.
Arigato gozaimasu, Sensei. Bye-bye.
Bye. See you again. Thank you so much.